happy to come and talk. We've been doing a lot of interesting things that have actually been made easier at Schlegel Villages because of the approach to care. And I'm going to talk about some of the work that we've done in terms of superimposing chronic disease management on top of the neighborhood teams. And the good news is Andrea is going to talk about their new curriculum, which is really going to shift the way that physicians hopefully work and collaborate. I'm going to start with a case, and this is actually a real case. I made up the name of the person, but this woman was 78 years old, and she was in another nursing home and had a very dense hemiparesis. She'd had a stroke, and the team had noticed that she was sad and not engaged and eating less and sleeping more. And the team said, we think this is depression, so they informed the attending physician. So the physician wrote an order in the chart and said, please complete a mini-mental. If it is above 16, then do a geriatric depression scale. If it's less, then do a Cornell. Let me know when you're done, and then I will see her. So what would you do? Would you say, yeah, sure, fine, we'll do it. No problem, we'll call you when we're done. Maybe we'll get to it this week, maybe next week. Would you say, no, you heard us, go see her? You probably thought that. Or would you say, you know what, she just had a DRS done in her most recent MDS and it's really high. Why don't you tell us when you'd want to go with the team to the bedside and see her? Right? This is actually taken from a case where I was the consultant and I happened to, with a geriatrician wait list of 6 weeks, which we think is great. I went and I found her in this state, and she'd been waiting for 6 weeks with these data to be seen for depression. Right? So physician culture over time, let's talk about docs. So this is William Osler. Notwithstanding that he was a misogynist, sexist person, he was still invented internal medicine as we know it. And he was quite ageist. You know what he said about pneumonia? I remember pneumonia is the friend of the elderly. That's him. So not a saint, but he did invent internal medicine. He did invent the formal teaching program for physicians. We learn medicine by actually seeing patients. And he established the importance of the clinical assessment and reasoning process, and he in fact invented evidence-based medicine. When chest x-rays came out, he said, let's study this and figure out how we can use this. But he said, he who studies medicine without books sails on an uncharted sea, but he who studies medicine without patients does not go to sea at all. So keep that in mind, because there's a couple of things that are true, right? If we don't experience medicine by seeing people, we're not going to be very useful. But I would suggest that in a day where we are now, where you have an entire team that must support the resident, if you ignore the team, you're not going to see either. Or if you are, you're going to hit the rocks. So through the ages, the physician was the quote-unquote master diagnostician. Like Osler, it was easy to be the master diagnostician because we didn't know anything. So he invented all the knowledge, and therefore he's the only one who had it, and it fit in his brain. Today, the problem is these patients' medical knowledge are way too complex. There's no way anyone can know all of this stuff, but we still sort of put this expert diagnostician on the pedestal. And let's talk a little bit about what we should be expecting in the future. So this is taken from an article by Alan Detsky, who's a guy at U of T. And so the master diagnostician of old, here's some really good patient-centered care. Right, let's wheel your bed out into the auditorium and all these men look at you. So the encyclopedic knowledge just from reading and seeing, very important, right? The impact about seeing and experiencing healthcare. Right? You can read all you want, but if you don't actually do it, it's useless. Generalist and a specialist. But that again, that's because he was the only one around. And there was something though that was going on back then which is really critical, which doesn't happen anymore. Is you get to follow patients and you get to see what happens. You get feedback. Did my treatment work or not? Right? We're in an age right now where you have a family doctor, but if things get really hairy, you go to the hospital, you see a hospitalist, but they change shift every week, and then you might see a few specialists. And if you're lucky, you'll see a nurse and a physiotherapist. but everything is fractured, everything's episodic, we lose that feedback, right? And without feedback, you can't learn. I'll get back to the feedback theme in the future. The problem, of course, is you can't have single experts because medical knowledge is exploding and patients are more complex than ever. So here's Dr. House. And this sort of reminds me of how I learned. Right? There was the attending. If you were lucky, they were good and nice people. If you were not, they were like Dr. House. And you get a bit of that eminence-based medicine. I'm the doctor. I know it all. Right? And essentially it's like here's the attending physician and his gaggle of little goslings, the students and the residents. And of course, there are no nurses on TV shows with doctors, but I learned that way too. It was just the medical team, right? Now, the expert diagnostician of today. You guys miss Star Trek? I do. So they're getting really slick, right? We can use all these electronic resources. We understand psychometric properties. Excellent communicators. As physicians, we're not really taught to speak to people in understandable language, you know. Idiopathic pulmonary fibrosis. Does anyone know what that means? It means you've got scarring in your lungs and we don't know why, right? But we have this terminology that obfuscates everything and makes people think that we're really smarter than we are. But we don't talk to people in a way they can understand, right? And we have all this issue right now in the news about homeopathy and naturopathic medicine. And at the source of that is the fact that these folks, for some reason, were not listened to properly or spoken with in a way they could understand. There's other issues, obviously, but that one always comes up. And again, the expert never sees anyone in follow-up. So we think we know everything because we've read the literature, but actually, I don't know what happens to you once you leave the hospital. No more feedback. The future. So according to Detsky and this student, Dhaliwal, extensive clinical experience and knowledge, recognize the risk that they are not perfect, and they use the EMR to get feedback. But what I have to add to that is you need to listen to the patient, because in that article, which was in JAMA, there's nothing there about listening to the patient. And we're going to talk about residents, because that's we're in long-term care. And you don't listen to the team, right? There's nothing in there. Again, Detsky's a great guy. Internal medicine, in turn, is very famous, evidence-based medicine, but in his articles, there's none of that going on. And I would suggest that if you don't do that, you're not doing your job. So, again, we need to shift. The traditional MD role, we're trained to label, figure out what's wrong with you, give it a name like idiopathic pulmonary fibrosis, prescribe tests, prescribe treatments. That's what we're trained to do. We're trained to write orders. I'm going to come to the chart. You don't have to be there. I'm going to write something. I'm going to sign it, and I know that you have to do it. If not, I'm going to get mad. That's how we're taught. We do things like physicals. We define medical issues. We answer the phone, especially if there's an emergency. We write orders. Sometimes we attend meetings, but I've seen some long-term care facilities where the docs don't come to the annual meeting. That's our traditional role. And this is from Stahl and Jamda in 2009. I love this. You've got to shift the focus from disease to dis-ease. Right? These folks are not well. They have chronic illnesses. They have chronic needs. They're no longer in their house. Their friends are not around anymore. Their family comes and goes. Right? It's dis-ease. What is going on? How can I help you? Right? And I think this is a very nice way to summarize it. So, shift in the way we make decisions. Basically, we come up with a diagnosis, we write an order, and usually, when I was trained, I wrote the order. Don't question it. That's how we were trained. Unilateral decision making, that's how we think, right? Here's a prescription, off you go, right? But what we're not trained to do very well is ask for input from others, ask for their help to solve problems. Following up, we don't, right? Don't listen very well. We could be teaching more, right? If I write an order on the unit for daily weights for a heart failure patient and people don't do it, the answer is not to get mad. The answer is to explain why this is important, right? It sounds simple, but it isn't done. And then set the example, right? Because I learned from Detsky. He's a great guy. believe me. But I learned that way. And it's not until I came across some really gentle yet firm nurses with me as a third-year resident that I actually learned how to look after residents. So what am I doing in terms of culture change? I'll briefly talk about our heart failure intervention, which really works well in the Schlegel Village because it builds on the neighborhood team. And essentially what we do is we take this disease, which is extremely common but generally under-taught wherever you go. We provide education to nurses and personal support workers, and then we teach them about heart failure and how to apply their knowledge to how they would deal with the heart failure person when they come into hospital, when they get sick, when the physician is around, how to monitor weights and why, right? Then we bring in the docs, give them their training, and the really cool thing is when we bring the docs to the bedside teaching that we've been doing with the teams, and the team presents Mrs. Smith, and they talk in terms the physician understands that, oh my God, the guys know what they're doing. And the penny drops when indeed the physician goes to listen to the chest and says, you're right, this is heart failure. Thank you. Right? So that's what we've done. So I'll skip that, but again, very briefly, one of the other things we learn in medicine is what's the next treatment? Right? We have algorithms, we have heart failure guidelines, we have diabetes guidelines. If the sugar is not low enough, do this. If the heart failure is still symptomatic, do that. Not talk to the person because they're getting really frail and maybe they're fed up and maybe they want to change tacts here. Right? And so the algorithms and the guidelines are like runaway trains with no way to get off the train. Right? When is enough enough? So, I'll skip that. Here's another question, speaking about heart failure. So Frank, he's got heart failure. He's extremely disabled from it. He's in a wheelchair. He's short of breath, brushing his teeth. I don't have long to live. I want to eat chips. And these are really good. This is the 25th anniversary of Miss Vicky's. And there's a contest for wine pairings, in case you're interested. So what do? Right? Culture change. What do? Do you let them? Do you say, I get the doctor and the doctor's going to lecture you on no added salt diets? Or you sit down and have a conversation and say, okay, I get it. You might make your heart failure worse. And he might not know that, and you say, oh, okay, then I guess I'll skip the chips. Or, like we've done, we've negotiated, let me know when you eat chips, we'll give you extra diuretics, which usually works. That way they can eat their chips and they don't get worse from their breathing perspective. And I would argue that's part of the culture change, that what we want to do is have physicians come in and start working with the teams on that. So what are my 3 top recommendations? I think one of the things we want to do is know your diseases, know your common diseases. Right? We know that diabetes management does not have to be as tight as it used to be as you get frail. We know that heart failure management is important because you feel better when it's more comprehensively managed. But we also know that these diseases approach the end of life, and that entails certain choices and certain framing of the discussion. Right? You don't have to go to hospital with your heart failure exacerbation because they're not going to do anything different, but we can manage it here. Model the flat hierarchy. I think most docs are well-meaning, and I think what you need to do for that person with the depression scale is say, you know what? We think she's depressed. We've observed it all. The tests that are and scores that are being collected show that she's depressed. We'll go with you. And you model it with your conversation with your PSWs and your RPNs, your RNs, and they'll clue in very quickly that, wow, these guys know what they're talking about. And in other words, for your physicians, be that feedback that they no longer have, and don't be shy, because that's the only way we're going to learn, is learning from you guys. Because when it comes to culture change and patient-centeredness, you are way ahead of the docs.
So I'm going to try and tell you what we've been doing with physicians around the province in 8 minutes or less. So this usually is an hour and a half long of the history of how we got here and what we're doing, but I'm going to try and compress it so that you can get a sense of what's going on. There's an organization in Ontario called the Ontario Long-Term Care Physicians, and we're an organization of about 400 physicians, attending physicians and medical directors working in long-term care. And over the course of the years, particularly with the new Long-Term Care Homes Act, we realized that there was a real opportunity for looking at there's a big echo, eh? What are physicians doing in long-term care? How can we enhance that practice? How do we build that capacity for that medical role in long-term care? And looking at the literature around medical staff models, medical directors in long-term care, there's really a strong signal now coming out of the literature that when you actually have an engaged medical staff, when you have an educated medical director, your quality of care improves. Your outcomes, your clinical outcomes improve, your emergency department visits go down, and generally things work better for the residents. And at the end of the day, that's what we're here for, is to provide as good quality care as we can for the people who are living in our long-term care homes. So what we decided to do as an organization was to look at actually what are the learning needs of the physicians currently working in the province. And we did what's called a learning needs survey, where we looked at the perceived needs and the unperceived needs. So we knew what was coming with the Long-Term Care Homes Act. Many of the physicians hadn't looked at it or weren't aware of what was coming in terms of the transformation of the system. So when we asked them about what do they feel they need to learn about, they quite easily could identify their perceived needs around some things around how to manage your medical staff, what it really is the role of a medical director, what is the legislation, how do I understand it, and then of course as good physicians, immediately, even though it was an administrative survey, immediately they went into all the clinical things that they need to learn about. So really trying to step back, and that's where we came up with also the unperceived learning needs. So we asked them things like, do you know much about quality improvement? They said no. And then when we said, what are your learning needs? They didn't say quality improvement. So we said, we think you need to learn about quality improvement, program management, and overall leadership. How can physicians be leaders within this system? And what's really fascinating, at the same time, I'm involved in quite a few provincial bodies, and sitting at the Long-Term Care Quality Improvement Program with the Ministry of Health, hearing the messaging time and time and time again that physicians are not the agents of change. We don't know how to engage physicians. We don't know what to do about this black box of providers that are coming into our homes. So we really felt we had an opportunity to do some education and really bring their abilities up. And be more present. So where we looked at, let's see what's happening. Where are we learning about medical direction in long-term care? Everyone knows in the legislation it's legislated, there has to be a medical director in every long-term care home. That person must be a physician in good standing with the College of Physicians in Ontario. Okay, so where's the training? There is none. We don't learn about it in medical school. There's nothing from the College of Physicians and Surgeons. There's physician management institutes that talk about leadership, nothing that touches into long-term care. There's a long-term care requirement that physicians who are doing an added year of care of the elderly in family medicine actually have to be exposed to long-term care, but nothing specific around medical leadership. In the States, there's a robust medical director curriculum, 36 hours. A few of us were brave souls, and we went, and we attended, and we heard for 2 days about coding and Medicare and all of those wonderful things, and how to get which pharma company to do what and to cover this. And we heard about all of their F tags and realized that although the bones were the same, the content was very different. I'm just going to move on. So what did we do? So myself and a colleague from Sunnybrook, Evelyn Williams, we sat down and decided that we didn't need to do anything with our spare time for the next 18 months. And we put together this medical director curriculum with a lot of iteration back and forth with a board of directors at the Ontario Long-Term Care. Ramesh Zacharias, who's one of your medical directors, was very involved in this as well in terms of that feedback loop. And really came up with 6 days of training, 2 days each, where we looked at the bare necessities we felt that physicians who are going to be medical directors in long-term care really need to get a handle on. Block 1, so the first 2 days, really what's the legislation? What's the compliance look like? What's the role of the physician in that? What does it mean when 4 inspectors come into the home and the physician actually is really wanting to talk to the DOC? Well, DOC might not be available that day. What's the role of the medical director, and what's our role in medical staff management? How do we deal with that physician who everybody's having difficult dealing with? How do we get them informed of what their role is? Block 2, the quality improvement was really exciting because this is around Residents First, what had been rolling out in the sector, but Residents First targeted staff and management of long-term care. It didn't target physicians. So we said, hey, how about physicians? Can we get that training? So we revised the Residents First curriculum to, for the physician group. And then the last block is around leadership and risk management. In the course of this, we were actually able to get some research funding through U of T, both through Baycrest and Sunnybrook, to look at if we do this curriculum, now that we've got it, we've got this great idea. A, is anybody going to come? And B, is it going to make any impact? So we were able to get some funding to look at both looking at our pre and post course surveys of the people who are attending it, but also doing some focus groups, both with the physicians who attended and also with the directors of care in the homes where some of the physicians attended. And then we also purchased a medical engagement survey that's used overseas in England around engagement of physicians in the healthcare system, and we were able to get some data. So this is where it got exciting. The QI, the first day, we had really good credits for the physicians. So physicians, for family docs want Main Pro C credits. And Main Pro C credits are really great. And so they came and we thought that's all they wanted. Actually, it was fabulous because they came, we said, what's your biggest issue in long-term care? How can QI help you? They all could tell us their issue. No one could tell us how QI could help. As the day went on, they went, oh, I can do that. Oh, I can do that. I'm going to do this. And when they went home to their nursing homes, they did things. They implemented new programs. They reviewed policies. They looked at safe prescribing. They did audits. They really did some exciting stuff. And then when we looked at, after the whole course, what happened to these physicians who went through these 3 blocks? They changed their practice. They were participatory in committees where they hadn't been before. One home came to me and said, I think my physician went to your course because he's asked to sit on our quality committee. And now we have to review our terms of reference because we didn't have him sitting on that before. Improved communication and collaboration. They're looking at quality indicators. They're actually looking at critical incident reports more. And one of the really exciting things about this, a whole bunch of them said, I understand the role of the director of care. Guess what we did not teach in the course? We had nothing. There was not one slide. There was not one thing on the role of the DOC. So these physicians went, took the training, understood the legislation, applied it back at their practice to appreciate the role of the DOC. And this is one of the things that we thought was really cool. Some of the interviews from the physicians, I used to guess what my job was, whereas now I feel like I know what my job is and I can do a lot more now. Right? Within a week of completing the course, I sat down with the nurse manager and the administrator and had a whole list of things. I think I gained their respect, or they were frightened, because I'm now on top in the position to advise rather than absorb. I'm no longer a passive participant. The directors of care. The medical director's listening and realizing this is not a simple job when you're at the other end. He's now able to anticipate what I need or what problems may come up. He can help direct the policies to go forward and to see whether or not we're doing a good job. I tell you, it's a plus for me. So that collaboration, that engagement, that being involved. And we actually did this medical engagement scale. It was a 30-item scale. It had a positive improvement. Overall, it was a very engaged group of physicians. But where they really shone, where they really felt the training helped them, was participation in decision-making and change, and having purpose and direction. So they no longer were just going in as a figurehead because they had to, because they were the one who'd been coming into the home and the home needed a name for the medical director. They now really felt they knew what that role was. So that was like the 101 quick and dirty. But thank you.
So this is still being run?
So we've run it now twice, and we will be running it again. We actually do it 3 days and 3 days because the quality improvement, we have a block in between so they can go home and work on projects. We're going to be running it January and May. So January 2017 and May 2017. If you're interested or you want information, just send me an email.
Is this optional at this point?
It's optional, and it's interesting because the wonderful thing for me is I actually had a medical director from my hometown come to the course last time, and he actually said, I've been a figurehead in this job, and now I know what can do. And he actually went home on the Saturday night, and we came back the next day, and we do a lot of small group in the training, and he came back and he said, ooh, what's the plan of care? How do we look at that? He said, I've been reading the Act. And he was really excited. Like he was just, I want to know if I can do this and I want to know about this. And so a lot of physicians, they haven't had that opportunity and in the medical director role haven't realized what the potential was. And he was really excited to go back to his facility and really work with them together. So it was exciting.
I'm just wondering if you could speak to initiatives that could help to address this earlier in the spectrum of physicians' experience around interprofessional education with entry-level programs. Are you aware of things that are happening at that level?
I'm not the expert on undergraduate medical education, but I know there's a lot more focus on interprofessional collaboration across the training. We have a long way to go, but it's certainly something that I think everybody is looking at and recognizing that we can only do our job well as members of a team.
I was just wondering if you have a slide in there on nurse practitioner, because now we've got more coming into long-term care and it's how they work together and we're not always sure.
So we actually, for our quality improvement training, it was actually open for nurse practitioners, pharmacists, and attending physician, as well as medical directors. The medical director role piece is really physician-centric, because that's who's in that role right now. Certainly for our clinical conferences, we are absolutely welcome and open for nurse practitioners, because we're all working together. And as you know, the attending nurse practitioner role is very, very similar, if not a carbon copy in the Act. Requirements of an attending NP are really the same as an attending MD in the Act. So yeah, great point. Part of the team.